So in this case, the patient obtained a head CT to identify the head injury, and the patient was identified with the epidural hematoma. And if you have any kind of bleeding in the head, you need to go to the OR to kind of reduce the pressure and evacuate the brain. Not the brain, evacuate the blood from the brain. Yeah, not the brain. You don't want to take that out. That would be a bad neurosurgical mistake right there. Right. So, yeah, you want to evacuate the blood. From a CT standpoint, this is what an epidural means. An epidural is bleeding in the brain. Specifically, there's a bunch of arteries that runs into the head, meaning the middle meningeal arteries. It goes in there, it ruptures for whatever reason. In this case, it ruptures because of the trauma. And if you have bleeding into the brain, this white thing that you see, I'm sure you kind of figured it out, that's not normal. Right down here, that's bleeding into the brain. So you go into the OR, the neurosurgeon is going to go there and evacuate it, and take out the blood. Okay, so that's our first patient. Second patient is the passion in this case. So we take a history of this build, and the key things that pops up is the orthopedic injury. We said the patient has a deformity in the leg. So what do we need to do with this? Well, we need to find out what exactly happened, but we also need to address this patient's needs. This patient presented was hypotensive and had poor perfusion in her leg. So we already done the first two, meaning we put direct pressure on the wound, preventing more blood loss, and we split the injury, meaning we put the leg into alignment, and hopefully the perfusion will go down to the distal portion of the leg. But if the patient's blood pressure is very bad, meaning it's hypotensive, going to shock, and the patient's losing blood, what do we need to do? We may need to transfuse blood to kind of replace whatever the patient's losing at that point. So that's when you hear all these fancy things from these ER shows that, I want 2 units stacked, this is what it means. Give me 2 units stacked, transfuse some blood right there. Okay? And but from a physical exam, I told you the leg was deformed and everything. So we need to make a diagnosis again. So we x-ray this lady's leg, and we see the leg's broken, but particularly with a femur fracture. This particular injury is bad in adult patients. You can actually lose a couple of units of blood, so it's not surprising that this patient went through hypotension and had poor perfusion. So you need to bring this patient into the OR and to bring his leg into better position. And at that point, the orthopedics will either put a plate at the injury or put a rod in it, just like the Tinker Toy says. They kind of put the leg back in alignment with metal and hardware. So this is a schematic. The patient has a broken leg. So what the orthopedic doctor does is probably put a rod in. It's like a big piece of steel. Drive it into the one part of the femur and drive the other part into the other part of the femur. Kind of holding position. Yeah, it sounds pretty graphic, but that's their I guess that's their thing. So basically, I just presented I guess how we think in terms of ER doctors. ER doctors are, unfortunately, we're kind of condemned by this. We kind of think quickly. We kind of see things in a very narrow span of window. And the things we always worry about are things that are acutely injured or have life-threatening events. And we want to act upon really life-threatening issues. I want to also hopefully brought up onto you the aspect of this particular profession. We're a profession of time. We want to take care of everybody and everything, and in our future, we are kind of in a position of taking care of America's population society. So this is my last slide. Is there any questions, comments? Yeah.
How long will it take for the healing of the fracture?
How long will the fracture will heal?
Yeah.
Yeah. Well, postoperatively, the fracture would probably, the patient would probably in the hospital maybe about 3 to 5 days to heal up from the operation. But to actually recover from this injury after this will take at least 6 weeks. And once you have a big injury like this, the patient will need to go through rehab. Meaning you probably have to go through some physical therapy or occupational therapy, PT or OT, for this to get her back in the functioning state. So it takes a little bit of time. Any other questions or concerns? Yes.
When you respond to the emergency and you do the steps, when you have to take them to the operating room, the same people who respond to the emergency operate on them, or the people in the hospital?
No, it's more like a division of labor. ER doctors work in the ER, meaning we take care of everybody coming in. But when we recognize a particular problem, meaning a patient needs to go to the operating room, we have the surgeons will take care of them. Meaning, if it's, as I said, a trauma surgeon will take care of it. If it's a neurosurgical issue, in this case, the neurosurgeon will take care of it. So the care is pretty specialized. So I take care of all things coming out of the ER. In the ER, there's also other things going on. Not everybody needs to go to the OR. Every patient I see that doesn't go to the OR. A lot of them gets discharged home. Actually, a vast majority get discharged home. So we see actually coughs and colds, sprained ankles, sunburns, anything you think about, heart attacks, endocrine metabolic disorders. So we see everything coming down there. If they need to be admitted, next week it takes care of them. Anybody else? Yes?
We just had a curiosity. The epidural hematoma,
Yeah.
shares a name with epidural that it gives to pregnant women during labor. What's the relationship between them?
With the relationship between epidural and the...
Epidural hematoma.
Oh, epidural. Oh. Epidural is a part of like a lining around the spine. So the epidural hematoma that I talked about, the lining in that area where the blood vessels are violated, so the blood vessel leads in the brain. However, the epidural you talk about for the pregnant lady, give them the analgesia, it kind of goes through that space to give the numbing medication, the analgesic, to numb the lady from waist down while they're pregnant. So it goes back to the same anatomical sheet that we're talking about, or where the injury, or where the action is, it's different. One's in the brain, the other one's in the lower back. Any other questions or concerns or things you want to talk about? Thank you, everybody.